Hello, and welcome to the Society of Critical Care Medicine podcast. I'm your host, Maureen Madden. Today, I'll be speaking with Doctors Kitman Y and Shanali Basu about the article, Evolution of Pediatric Critical Care Medicine, Physician's Clinical and Academic Profile by Gender, which was published in the October 2024 issue of Pediatric Critical Care Medicine. To access the full article, visit pccmjournal.org. Dr. Kitty Y is a critical care specialist and director of Critical Care Medicine Fellowship, and Dr. Shanali Basu is a critical care specialist, associate chief of critical care medicine, and associate director of critical care fellowship, both at the Children's National Hospital in Washington, D.C. So welcome to Dr. Y and Dr. Basu. Before we start, do either of you have any disclosures to report?
I do not.
Nothing related to this study.
Excellent. I'm so very happy to have both of you here and to talk about your publication. So congratulations, first of all, on having that published. To really understand background interest in this topic, why did you choose the focus of this publication? And if either of you have had any prior research on it?
Yeah, so this going back historically all started with just a casual conversation with one of the other authors, Dr. Murray Pollock, on this paper about abstracts and how many of them end up getting published. And these are abstracts submitted to major conferences. And we saw that there's about a 40% publication rate. And then that got us thinking to, the whole point or intent of doing research during fellowship. And we looked specifically about abstracts done by trainees. And given the ABP requirements, we know that it is there, but we started to think about the research component of fellowship and really what the end game with that was and what impact that has and what you end up doing for the rest of your career. So we then looked at all the fellowship programs and graduates of different fellowship programs throughout the country to see if there are different patterns between different fellowship programs and what their graduates end up doing academically. And we used publication and H-index as a metric, and we can talk a little bit more about the validity of that. And so looked at different fellowship programs and used the fellows that graduated from those programs as a surrogate for what the program was, and then compared different ones. And we found, there's more academic programs. Graduates from more academic programs end up working in places that are academic, bigger ICUs, and end up having more publication output later in their careers. And then again, casually talking about the cohort we had and expanding it, and then looking specifically at different factors. And Kitty brought up, what about women in critical care? Because there's so many other factors that may impact these metrics. And kind of I'll pass it on to her to how we frame our next study, but a lot of interesting thoughts came out of it.
I'm going to take over what Shanali was saying. I've been involved in sort of medical education and fellowship education sort of since my graduation time. And it's always interesting to me to see where the fellows go, right? Like after they graduate. So looking back at my own career trajectory, like there's a moment of time that I do feel like that my focus is not on my academic productivity, right? It's definitely on my young family and how to really balance work and family. So looking at gender is something that I'm interested in to see if other individuals who are in this field, which is demanding when it comes to clinical work, feel the same way, or do the career trajectory get impacted at a certain time point of their life when they feel like they have to take a step back from where they are right now, take a step back in, taking care of things outside of academic productivity, and then later on continue to build their career. So Shanali and Murray have had this data set for a while. So we just sort of like went back in and build on it a little bit more. And then that allow us to give us sort of like a glimpse in, the gender difference of the academic profile in peds critical care.
So having looked at your publication, as you said, you're looking at the gender differences and you're looking at the H-index, which is productivity and impact. So how many articles have been published and then how many citations have come from that publication. And then also looking at academic rank in the basis of, you chose 5-year increments for looking at the course of your career, early, mid to late, and what academic rank had been achieved. So I'd love for you to kind of briefly give an overview of what you found for your research, and then we can dive into a little bit more about why these may be the right metrics or just a starting point.
Yeah, I mean, I can talk a little bit about why we started, our first, again, going back to that last paper with H-index. And again, we, continued using that same metric here. Historically, a lot of the surgical subspecialties, and that's where most of the literature is using H-index, uses that as a very objective cut point for a different rank. And again, the H-index in surgical specialties is often very different than in pediatrics and pediatric critical care, just given the nature of the publications, and that there, not often as many single case reports or single surgical experience that get cited. And so, we use that again in pulling people's H-index. We realize that there's, there's flaws in that system too, because it doesn't really take where authorship is, so middle authorship that gets cited gets you a point or however the points go on. And commitment you had to that study may be variable based on whether you were first author, second author, or a middle author in a slew of authors. But, that was one of the things we thought was at least published on and could at least be referenced when we were doing it. But again, lots of flaws that we, discovered with that system. But it was one of those things. It was the best system we had that we would be able to find something for everyone.
So I'm glad that you recognize that it may have its limitations and be flawed. Talking in the context of academics in general, not just medicine, but historically had been that publish or perish mindset. And that's how your rank was, you were able to achieve and move up in the academic rank. And now we know over the time that there's been some movement to change how you're evaluated for productivity. And it's not just publication, it's not bench research or clinical research, but maybe people are now taking on the safety and quality roles, they're taking on other QI pieces, they're taking on education roles, they may take on other academic ranks. So that would not be captured within the H-index, as you said.
Correct. So I think the reason why we use H-index for this particular publication is because it's publicly available. We did a search on Scopus and or ResearchGate, like you mentioned before, and it's something that just go with sort of like the data that is readily available on public website. We also use MPI. We confirm things on an American Board of Pediatric. These are just what is available to us right now. Again, I think for this particular paper, we want to raise an awareness that there might be a difference, but by no mean that this is the best metric that we can find to define somebody's career or tell the story of what is happening, for a physician of different gender that is going through their career as a pediatric critical care specialist.
Talking about women, there's been lots of conversation over the years, and it sometimes is a question about whether or not these are valid items to study, such as work-life balance, the recognition that females are the childbearing individuals. So looking at that, how does that impact full-time versus part-time, or even, as you said, stepping and taking time away?
Yeah, I think there is this unrecognized publicly awareness that women who are finishing fellowship are at that childbearing age. And so they may have different work output than their male counterparts. And again, the landscape is changing with parental leave. There's fathers or other caregivers who are taking time away. But historically, it was this kind of recognition that at that point in life, women may not have the same output over that amount of years. And where I've really learned to appreciate that people recognize this is in participation in our institution's promotion committee and just listening to the discussions of different candidates and their productivity over time. And there is always this, and it's not discussed, but there's always this recognition that they have two young children or something like that, and not in a negative or pejorative way in that, and why didn't they do more, but in a recognition of they've been so successful and they have young children. And so I think over time it is being more recognized and there's more appreciation of the multiple kind of pulls in different ways. The other thing I was going to mention from kind of your last question is that I do also now fully believe that there's different scales or different metrics in different institutions. So what may constitute in one promotion to associate professor in one institution may be drastically different than associate professor in another institution. And we fully saw that, though it wasn't reported because we're not comparing institution to institution. We saw some individuals at one institution where their H-index was equivalent to what a professor's H-index as an assistant professor to what a professor's H-index at another institution is. So I think that's another thing that is I don't know if I would call it a flaw, but something to consider, that there is not a universal, you have to have a number of 10 to go up to the next level. And again, not taking into any consideration all the other things that impact promotion. So service to hospital, service to community, service to field. Those aren't really measurable by any index or by any number.
Absolutely. And I love that you brought that up. So I've been in critical care, pediatric critical care specifically, for many years, and I'm not going to tell you how many, but I did have the good fortune early on in my career to work with some of the individuals who really developed pediatric critical care. And we were talking about, so Murray Pollock is on this study with you. He's identified as one of those individuals, and he's contributed a huge body of knowledge to this. Peter Holbrook, Alan Fields, we could name so many, but they're all male. So looking at the history and also looking at the data, I think it has to be taken also in the context of what the environment looked like at the time. Critical care as a discipline is really not that old to start with, but many of it were men who started it and have done and built a very robust discipline. And now you looked at the data, and in 2022, many more female. So it actually was 72% in first year of fellowship were female versus 10 years prior, it was only 47%. We are seeing that shift. And to look at some of the data too, your rank has time associated with it also. The conversation about how many achieve full professor versus more predominance of females at assistant and associate, there's so many things to pull out of there. And as you were saying, to the viewpoint now of recognizing that there are many other areas of contribution, and not all academic institutions are uniform. There's no consistency where you are. I've seen that in my own environments over time. So I'm so happy to talk to you, because there's so many things in here that are rich that still need to be discussed and brought out. And you've taken the method of traditional research to try and bring it to the forefront. And I understand that you're continuing, or there are individuals you work with that are continuing on this journey of looking at the gender diversity.
Yes. So I think we wrote it in the limitation of the study, right? I think for a study such as this, which is sort of one glimpse into one time, looking at everybody who we can get the publicly available data, there's definitely flaw in the study. And in order to get a better understanding of career trajectory, one of our star fellows who I have gotten permission to talk about this, Dr. Prabhakar, has started taking the initiative to start planning a qualitative study as a continuum of this study, because we really want to understand the story, the trajectory of individuals, at different career time point, what their story is like as a pediatric critical care female physician. What do they value? What are the factors that drive their career to be the way it is? So we're hoping that study will, in a few years, hopefully everybody will see it again at PCCM, we'll see. But we're hoping that we will get some more rich data to describe people's career trajectory in a more granular fashion, instead of just like a number and an H-index and a rank.
That's stuff that I'm going to look forward to seeing, and hopefully it's something that comes out pretty soon, and then lots of other people build upon it. One item I also wanted to touch on, and you did mention it also in your limitations and your conclusions in this publication, was about burnout. So recognizing that this is, a high intensity environment, high stress, high expectations, long hours, and then, as we said, trying to balance your personal and professional lives over time. I just wanted to get your take on how you think burnout has affected some of the statistics and conclusions that you were able to draw in your study.
Yeah, I think burnout is definitely real and is a focus of a lot of how we shape training and faculty mentorship and faculty development, is to try to train the best critical care physicians who are doing cutting edge things, excellent clinical work, but still protecting them from the burnout that comes from the high stress environment that we work in and the demands of all the things that are, required of an intensivist. I would be very curious to see, and we didn't do this, although I'm sure in some world this data would exist if it could be done, is a cross between what we found with individuals and the workforce study that I think it was Ettinger did. It just came out recently, looking at, and again, it was survey based, but looking at weeks of service and hours of clinical demands and seeing, if there's some associations there. Again, what neither of them really represent is all the other things that don't have a measurable metric. Cost of living, how many other responsibilities you have outside of work. Are you working extra because the compensation is not what you need? Do you have a partner who is working certain hours? So I think there's so many things that we're hopeful that this interview-based study that Dr. Prabhakar is doing will be telling people. Have been very, very enthusiastic about being interviewed, because I think people want to tell the story. I think people want to share why they did what they did, why they do what they do, and why they choose different things and different lifestyles as far as shift work or hours or weeks. But I'd be curious to see what the overlap is, because I'm sure there's associations between burnout, output, and how much one is working.
I think that you're absolutely correct that that's going to be some very enlightening data to come out and really demonstrate that it correlates to the conversation. And now we're just providing you the evidence to show what we've been talking about is true and it has value in how we can address it, because individuals who are so highly trained and have such experience, we need to figure out how to maintain them in the environment for long term. And some of the things that you looked at that weren't necessarily statistically significant was the size of the units. You looked at academic versus non-academic, and the non-academic tend to be smaller in my own experience. And when people shift into that, is there a shift later in career? Maybe better pay is there, better schedule, less stress because it's not the huge academic center, and the population of patients that come in don't necessarily have the same complexity and high acuity. So thoughts about that?
Yeah, we were looking at that. I mean, surprisingly large number of individuals actually choose to stay in an academic center, right? So we thought we saw a small trend of maybe later in the career, there is a trend towards going to the non-academic unit, but we thought the trend was only in male, not in female. But I think now there's also some protection of staying in an academic center too. Like you said earlier on, when you have worked for some period of time, you probably have earned the ability to maybe like not do as many night calls and maybe take on other responsibilities that is in the hospital. So I would say that we don't see a big drop off in the people who are in the academic center. Surprisingly, like a lot of the individual, even at the professor level, and or 30, 40 years out of critical care medicine, they still choose to stay in the academic center.
The other thing that I would add is, if you go back to, and again, this is my history as a program director, Kitty being a program director, if you go back to the very beginning, this is the only thing that they know, right? When fellows are coming in to train, they train in academic centers. Their mentors are clinicians in academic centers. And so that is the life that they know. The way that fellowship is structured, it's structured with usually 50% research time, right? 50% clinical. That is the structure of an academic intensivist. And so when you spend 3 years where that's all you know, you end up finishing at the end of fellowship thinking, what's your first job? Your first job is typically going to be something that is familiar, what you know, what you've seen, and what you've modeled for 3 years. Whether it's true or not true, I think there is a lack of desire to leave academics immediately out of fellowship out of the fear, whether it's valid or not, that I won't ever be able to get back into it. If I go non-academic, if I go community, I'm not going to get back in, which is by no means true. And actually, I would imagine size doesn't really matter. And a lot of smaller units have less extra levels. And so your need to be functioning at the highest of your abilities is much more, when you're at a place that is smaller, maybe community center. And I just think the way training evolves, people are being trained to become academic. And I think that's where they feel that they have to stay because that's what they know.
Yeah, I think that's a very true statement. The other piece that I've observed over the course of my career is you now have been surrounded by a large number of people who are encouraging you and supporting you and mentoring you, and to step out and say, okay, now I'm the only one here, or there's just a few of us, and that level of resources and support doesn't exist anymore. I truly feel that everybody needs to have that mentorship to continue to grow and develop, and the academic environment traditionally is where you're going to find it. So our time's almost up, and I want to make sure that you have both had the opportunity to mention everything in the brief time that we've had together. Shanali, is there any final things you'd like to make sure we hear?
I think the biggest thing is I'm just very excited to hear the results of the interview-based study that our fellow is doing, because it's, I think, a way to get the story out there. And it would be lovely if it wasn't just females, if it was both men and women. We used a listserv that was a female pediatric intensivist listserv. I haven't found one that has both genders, but just to hear stories from people like, why did you go where you went? And what were the things that made you successful? And what were the things that were hurdles for you? And I think what that would help us do for fellows and junior faculty is to allow to provide them that mentorship and to help them navigate their careers and make them successful. Every way we function is only by what we think is the right way to do it, right? And what we think is the right path and what we think, will be the things that will make them successful. But it'd be interesting to hear the stories. And so I'm looking forward to that.
Kitty?
Yeah, so I think, I am humbled by the fact that this publication has generated a lot of discussions, like amongst even like within our group and people who I have worked with before. And this is a start for us to really study the academic profile and or the trajectory of career. This old metric is probably outdated. We need to really look at our career as a whole and rethink our value of like what is considered a successful career, right? So that combined with really looking at the study that is coming out, some of the other data about workforce, we're hoping that it would paint a better picture for future trainees about what a career in pediatric critical care can look like and will potentially look like.
I want to thank both of you first for taking the time to talk about your manuscript with me. I think it's really important information, and clearly you have made it a springboard for other people to continue to work on this and bring it out into the community of pediatric critical care and open the dialogue. So hopefully it has some sweeping impact over time, but we'll have to wait and see. So this concludes another episode of the Society of Critical Care Medicine podcast. If you're listening on your favorite podcast app and you liked what you heard, consider rating and leaving a review. For the Society of Critical Care Medicine podcast, I'm Maureen Madden.
Maureen A. Madden, DNP, RN, CPNC, AC, CCRN, FCCM, is a professor of pediatrics at Rutgers Robert Wood Johnson Medical School and a pediatric critical care nurse practitioner in the Pediatric Intensive Care Unit at Bristol Myers Squibb Children's Hospital in New Brunswick, New Jersey. Join or renew your membership with SCCM, the only multi-professional society dedicated exclusively to the advancement of critical care. Contact a customer service representative at 847-827-6888 or visit sccm.org/membership for more information. The SCCM podcast is the copyrighted material of the Society of Critical Care Medicine, and all rights are reserved. Find more episodes at sccm.org/podcast. This podcast is for educational purposes only. The material presented is intended to represent an approach, view, statement, or opinion of the presenter that may be helpful to others. The views and opinions expressed herein are those of the presenters and do not necessarily reflect the opinions or views of SCCM. SCCM does not recommend or endorse any specific test, physician, product, procedure, opinion, or other information that may be mentioned.